the right one. So we're going to talk about this ever-elusive chest mass. So like, what is that? Alright, so I'm from Miami, if most of you don't know, and when I get a little nervous, so actually it's known for all things chonga, pitbull, and all things beach, and when I get a little nervous, the accent comes out in full force. So we have this guy, right? He's a 54-year-old male. We'll just call him Joe the Plumber. So Joe the Plumber, like 30 years ago, he had like this laryngeal mass that got resected, tracheostomy, just like 2 months ago, he started noticing this sternal mass. The sternal mass was painful, he had this weight loss, he decreased PO intake. Then about a month ago, he presented to this whatever hospital, and they kind of just treated him and sent him. Today he's coming to us talking about that he has the same pain, same story, but no cough, no shortness of breath, no nausea, vomiting, no dysphagia. He's never smoked before, and he's got this distant marijuana history, but otherwise his family's fine. So on our exam, pretty much we get the same story as the triage, other than the fact that he's also seeming weak, pale, and like Jared said, the mass is firm, non-fluctuant, mildly tender, and then no kind of suggestions of infection. So it's a labs. So the labs are significant for a lot of things, and kind of these are just the pertinent values, but the blue ones are even more pertinent than pertinent. So the hemoglobin is low, but it's a normocytic anemia. The sodium is low, but we'll get to that. The potassium is also high, whatever. The creatinine is high, so there you go. Okay, and the calcium, this is where the money is. The calcium is super, super high. And the ionized calcium is still high. So this is a for real super high calcium. So in the urine, it's significant for a super amount of protein as well. So all of these things are pertinent. Wait, values are not on fleek. So the images. So the EKG pretty much shows normal sinus rhythm, 190, animal axis, whatever, no STL signal elevations. I'll say this is normal sinus rhythm. Moving along. So this one, this chest x-ray. Let me talk about this chest x-ray. Not the best chest x-ray. And this reticular nodule opacities, I don't buy it. And we'll get to that. And on lateral, we see this. Like, what is that? I don't even know what that is. And again, I know like this really non-specific whatever that they're calling reticular nodular opacities. So then I was like, at this point in preparing my presentation, I was like, I'm super nervous. I don't know what to do. So I call my girl. And she's like, girl, get it together. You can do this in your sleep. This is Mika, our class kid. So let's go back to the problem list. So he's got lots of problems, super problems. He's got problems in his history, his physical exam, and especially in his labs. He's got these constitutional signs, his history of his mass. He's got now chest pain. On physical exam is pretty much only significant for paleness, which hello, he's anemic, and also this mass that we've talked about extensively now. And in the labs, I'm just gonna, in word form, he has a normocytic anemia, he's hyponatremic, he's got renal failure, he has hypercalcemia, hyperkalemia, and on those images, he has like this soft tissue swelling, bony swelling, and possible reticular nodule opacities, but possible litigations. I'll get to that. So my initial thoughts. So first, I wanted to break this down by what his real problems are. And his first real problem is his hypercalcemia, and that's for me at least the most interesting. So there's many causes: primary, secondary, and tertiary hyperparathyroidism, malignancy, multiple myeloma, lymphoma, Paget's, immobilization, increased vitamin D deficiency, increased vitamin D intake or production, or sarcoidosis. Renal failure is a bunch of stuff. If you remember from step 1, we had to like go through them all: pre-renal, intrarenal, nephritic and nephrotic syndromes, and in particularly primary amyloidosis when you talk about nephrotic syndromes. And you can probably see where I'm going with these highlighted things. There's a pattern here. And now with this hyponatremia, cool story, bro. It's not really a hyponatremia. So the first thing you want to do when you're looking at hyponatremia is look, is this a for real hyponatremia? And in this case, it's not. So you want to look at the serum osmolality, and in this guy's case, it was 280, which is normal. So in this case, is this a pseudo-hyponatremia, and that's either caused by hyperlipidemia or hyperproteinemia. The plot thickens. So these reticular nodular opacities, this is what they really should look like. I don't know if ours looks the same. And that could be caused by silicosis, pulmonary sarcoid, or lymphangitis carcinomatosis, which I don't think these are particular non-neuropathies, but be that as it may. He's also got a normocytic anemia, which can be caused by a bunch of things, including renal failure, parvo, pancytopenia, metastatic disease, hemolysis, and malaria. Proteinemia can also be caused by all those glomerular diseases that we won't get into, and multiple myeloma as well. The hyperkalemia is probably most likely explained by the renal failure. But again, it can be caused by increased release from the cells, like crush injuries, or it could be by decreased excretion from the urine. And then there's stromas. Yeah, I don't know what that's all about, and we'll get to that. So at this point, I'm in my presentation, I'm like, oh yo, I'm super nervous. And so I call my boy Jared, and boy Jared is like, don't worry, boo-boo, you got this. So I was like, I don't know, he's too perky. I need to go with somebody who's gonna keep it 100 with me. So I go to my girl, she's like, girl, bye. So then I was like, all right, I got this. So then I'm gonna go look at, so I'm looking mostly at my hypercalcemia. That for me is the most interesting and probably narrows down the differential for me the most. And when we look at hypercalcemia, there's kind of an algorithmic step-by-step way that you can look at it. First, you want to repeat it. Is this a true hypercalcemia? And in this case, we know that he had an increased calcium, but then he also had an increased calcium. So it's true, it's for real. Then you want to measure the PTH, which we don't have in this case, but that's something that we want to consider if we want to kind of triage this to what kind of, what's causing the hypercalcemia. Is it a primary parathyroidism? Is it, some kind of a malignancy, and then so on and so forth. And then we also want to then look at, is this real hyperparathyroidism, or is this a parathyroid hormone-related peptide that's causing something similar? Anyways, so looking at hypercalcemia, first and foremost is hyperparathyroidism. Usually it only increases your serum calcium to about 11, and your serum chloride to about 103, or greater than 103. And in our case, he had neither. He had a calcium of greater than 16.9, or he had a calcium of 16.9, which is much greater than what's normally seen in hyperparathyroidism, and his chloride was 96, which is much lower than what you should see. So we're just going to rule that out. Malignancy possible, if he's got a hypercalcemia secondary to parathyroid hormone-related peptide, that could be causing this hypercalcemia, and that's usually seen with a calcium of greater than 13. Fine. Multiple myeloma, that sounds legit, can be caused by either bone breakdown or osteoclast activation. And lymphoma, also, same concept, either osteolysis or parathyroid-related hormone. So we'll keep those all on the board. Immobilization, he didn't say anything about that in the triage, so X. Increased vitamin D, he didn't talk about anything about increasing his diet of vitamin D, so we'll X that. And extrarenal production kind of just goes back to all these other differential diagnoses. So we'll just chalk that up to other stuff. And then granulomatous diseases like sarcoidosis and tuberculosis. Also can increase calcium by macrophage activation of calcitriol, which increases calcium absorption. And also parathyroid-related peptide hormone is also associated with it. So, I don't have my presentation. I don't know what's next. It's going to surprise me. Oh yeah. So at this point, I just see my boy to just give me encouragement. He's like, damn, mommy, I'm getting it. All right, so what about this mass? So it's got this sternal mass, and let me just tell you that I went through all of these, and none of these sound good, most of them at least. So we'll just not even go through that. But there are two that do sound good, that kind of fit with everything else that we've been talking about, and that's the plasmacytoma and the lymphoma. So yes, Queen, thank you for the encouragement, guys. And neither of them are here, but they're encouraging you from far away. So lymphoma, that's the first thing. Pretty decent, kind of things that are in favor are the anemia, the hypercalcemia, especially in HTLV1, T-cell type lymphoma, Hodgkin's lymphoma. He's got this history of like remote cancer, maybe there was some radiation, now there's some secondary cancer going on. He's got this laryngeal tumor. Was this like an EBV-related tumor, and now he's got some EBV-related lymphoma going on? Who knows? He's got the constitutional signs, he's got the weight loss. The skin is a potential site for an extranodal development of the lymphoma. It can present as a solitary lesion, and he does have this chest wall mass, which it can present as. But again, He's got normal platelets, he's got a normal WBC count, he's got no lymphadenopathy, which is like a big red flag, no cough, no shortness of breath, no fever, and no night sweats. So, maybe not. Malignancy, like I said, he's got this history of cancer, he's got the constitutional signs, kind of the chronicity of it all kind of does fit, and the parathyroid-related peptide hormone can kind of create hypercalcemia if you did have a malignancy. But laryngeal cancer usually spreads locally, so I don't know how it would go from here all the way to here, so whatever. There's no lung mass on imaging, and he doesn't have a smoking history for this to be some kind of squamous cell carcinoma. And infectious, not so much, right? There's really nothing suggesting he's got normal vitals. He doesn't have this mass, doesn't seem anything infectious. It's non-fluctuant, non-erythematous, no warm, and the chronicity of the symptoms just don't fit. Unless you're thinking about a fungal or like a TB-related infection, and we'll get to that. So this is a weak sauce diagnosis, so we'll just next it. So the granulomatous diseases are more nuanced. Sarcoidosis and tuberculosis in particular. So it can present with hilar fullness, and the radiologist or whatever this preliminary read does say that there's bilateral hilar fullness on the x-ray, although I'm not really impressed by it. It can present with chest pain, fatigue, malaise, and weight loss, which he has. Hypercalcemia, which is directly related to the extrarenal production of the calcitriol, and it can present with a nodular lesion on the chest. But again, there's no cough, there's no shortness of breath. Anemia, which our patient has, is uncommon in these diseases. And also, so he has these things, and these are kind of non-specific, but leukopenia, thrombocytopenia, and eosinophilia are sometimes seen, and we don't have that in our patient. And there's no obvious risk factors for TB, and he doesn't, and since we're considering maybe those reticular nodular opacities or lytic lesions, those don't happen in granulomatous diseases. So, looking at the chest x-ray, this is what bilateral hilar fullness of sarcoidosis should look like, really nice and full. This is our patient. Not that impressive. This doesn't look the same. And when you really look closely, you start seeing some hypodensities in these areas. And then you have to think again, maybe this is something different. So, which brings me to multiple myeloma. Pretty much everything fits. He's got pain with movement on his chest. He's got increased serum calcium. He's got an anemia. He's got decreased renal function. He's got proteinuria. He's got this pseudo-hyponatremia. He's got a mass that maybe is a plasmacytoma, which can present in multiple myeloma. It's like a localized presentation of the myeloma symptoms. And he's got these constitutional signs. The only thing that kind of goes against is that he's young. He's 54, and it usually comes in 65 to 70-year-olds. But this is where the money is, I think. So just kind of being thorough, Wegener's we won't even talk about. Abscesses and TB we kind of went by. Neoplasias are probably more likely in this case. Vitamin D toxicity, we're saying no. Congenital, he's pretty old to be presenting with a new congenital condition at 50 years old. Sarcoidosis, we talked about, which is a legit possibility, and he has no signs of rib trauma or no rib fractures, and he does not have a history that he got into a fight or anything else. And hyperparathyroidism we kind of ruled out because kind of the labs just don't fit. So all roads lead to multiple myeloma. So what I'm thinking is multiple myeloma with a sternoplasmacytoma and a test to send out would be the urine and serum SPEP with it for looking for an X spike. Other things you could look for would be the rest of the CMP that we didn't get. We can look for peripheral blood smear, which could show those rouleau formations. We can get a PTH level, which was kind of the next step in our differential diagnosis for calcium. We can look for a vitamin D level, PTH-related peptide parathyroid hormone-related peptide. And then CT chest would be helpful in kind of showing us what this mass is all about. And then obviously definitive would be either a mass biopsy or a bone marrow biopsy. And if we're thinking more sarcoidosis, we can send ACE levels and then also biopsy the lung or the chest wall to mass. So now I'm pretty much feeling myself that I got this, yeah? Like Olga's feeling himself in this condition. So thank you.